Welcome, everyone, and thank you for joining us for today's session. This presentation is part of the OASAS Provider Webinar Series designed to support New York State OASAS certified providers in understanding key clinical, operational, and regulatory topics. My name is Shazia Hussain, and I'm the Director of Medicaid Program Policy and Evaluation within the Division of Addiction Treatment and Recovery, also known as ATAR, at OASAS. And I'm here today with my colleague and subject matter expert, Jean Martin. Jean, would you like to introduce yourself?
Thanks, Shazia. As you said, I'm Jean Martin. I'm an associate attorney with the Division of General Counsel and Risk Management at OASAS, and I'm happy to be here to discuss utilization review.
Before we begin, please note that the resources and information shared in this presentation are provided as is and for educational purposes only. They do not replace New York State laws, regulations, or official OASAS guidance. This presentation does not constitute legal advice, and programs are encouraged to seek their own legal counsel as needed. The information shared today is accurate as of July 24, 2025, the date of this recording. Furthermore, we would like to acknowledge that these sessions are not meant to be exhaustive or cover every policy, regulation, or billing rule in full detail. Instead, they're designed as a starting point to highlight key concepts, clarify common questions, and connect you with resources that can help you and your team stay aligned with current expectations. Today, we will be focusing on utilization review, specifically what providers in OASAS certified programs need to know about managed care utilization review processes. So thank you for being here again, Jane. Can you start us off with a high-level overview of what utilization review involves?
Yes, absolutely, Shazia. Utilization review, or UR, is essentially the process health plans use to evaluate whether the services being provided or proposed are clinically appropriate. In addiction treatment, that means looking at the level of care, the treatment plan, and whether the ongoing services are aligned with medical necessity. It's something that affects all phases of care from admission to discharge and has direct implications for reimbursement and compliance. You can use the link or scan the QR code on your screen to access the UR guidance document.
In this presentation, we'll be covering the major components of the managed care clinical utilization review process, including applicable timeframes and related documentation for addiction services delivered in OASAS certified programs. While we will touch on many aspects of managed care, topics like grievances and appeals are handled in a separate presentation. Our focus today is specifically on the clinical review process and the documentation that supports it. In the meantime, information regarding grievances and appeals may be found on the New York State Department of Health and the Department of Fiscal Services websites, which can be accessed using the QR link on your screen. So Jean, let's start with some key definitions. These are terms we hear all the time: prior authorization, concurrent review, retrospective review, but it's helpful to unpack how they actually play out in practice. Can you walk us through each of these?
Sure, Shazia. So utilization review is the broad umbrella term. It includes any process where a health plan evaluates whether care is appropriate. That could be before, during, or after treatment. Prior authorization happens before treatment starts. A plan might say, you need our approval before you admit this patient or start this service. But in New York, for OASAS certified addiction treatment, that's mostly prohibited. We'll talk more about that later. Concurrent utilization review is when a plan checks in while care is ongoing to assess whether the current level of care is still needed. In our world, that includes tools like the Locator Concurrent Review module. Plan notification is more administrative. It just means the provider has to inform the plan that someone was admitted and submit an initial treatment plan within 2 business days. And retrospective review is a look back. It's when a plan reviews services that have already been delivered to decide if they were medically necessary. This often happens when prior or concurrent review didn't occur.
All right. So to underline, these processes are all about determining medical necessity, but the timing and the required actions differ, which is important for providers to keep straight. Let's talk about Locator first. It's one of the main tools guiding these reviews, and I know many providers use it routinely, but there are nuances in how it's applied. Can you walk us through that?
Sure. Locator 3.0 is the tool approved by OASAS for determining the appropriate level of care for individuals with substance use and gambling disorders. Providers use it at admission to guide initial placement decisions and also during concurrent review, particularly when a change in level of care is being considered. As a clinical decision support tool used statewide to identify the most appropriate level of care for someone with addiction. What makes Locator valuable is that it walks providers through a structured assessment of the individual's medical, behavioral, and social needs. It doesn't replace clinical judgment, it supports it. It ensures that the recommended level of care aligns with clinical evidence and best practices. Within the clinical review process, Locator also plays a key role in helping providers clearly document the rationale for treatment decisions. This supports medical necessity and helps ensure that the care being provided meets the expectations of the health plan. Just as important, it strengthens communication between providers and plans. By offering a shared language and framework, Locator makes it easier to explain the clinical reasoning behind a level of care recommendation, ultimately facilitating timely authorization and support. Ultimately, Locator promotes transparency, strengthens collaboration between stakeholders, and ensures that decisions remain focused on the individual's needs.
So you mentioned that providers use the locator during concurrent review. Can you say more about how the concurrent review module fits into this process?
The concurrent review module within Locator is used when the individual is already in treatment and the provider is continuing services, whether at the same level or transitioning to another. It helps providers reassess the current clinical picture by promoting updates on risk, functioning, treatment response, and progress toward goals. That updated information supports continued authorization by demonstrating that the ongoing care remains clinically appropriate. Health plans use the same module during their reviews. So when providers use it correctly, it creates a shared framework for clinical decision-making. It makes it easier for plans to understand and agree with the provider's rationale because it's structured in a way they're familiar with.
So the locator not only guides care decisions, it strengthens documentation, helps avoid service interruption, and builds consistency between the provider and plan.
Exactly, and it's important to note that Locator is a required tool that is to be used by all OASIS certified programs. Additionally, health plans must also use Locator unless they've received specific approval from OASIS to use an alternative tool.
All right, so this isn't just a guideline, it's a regulatory requirement that applies across the care continuum. And for those who would like to dive deeper into documentation and how it connects to this, we cover that in a separate presentation called Enhancing Clinical Documentation in Addiction Treatment. And that session walks through how your treatment notes can align with Locator and reflect a clear clinical rationale. So one of the key provisions in New York State insurance law prohibits prior authorization for addiction treatment, but there's still some confusion around this. Can you clarify what is and isn't allowed under this rule?
Definitely. New York State insurance law prohibits insurers from requiring prior authorization for inpatient, residential, or outpatient addiction treatment services at facilities certified by OASAS. That means if a person needs residential care or is starting outpatient treatment, the provider doesn't need to wait for plan approval before admitting them. You can admit and begin treatment right away. But this doesn't mean no communication with the plan. Providers still have to notify the plan within 2 business days and submit a treatment plan. That's where some of the confusion comes in. Even without prior authorization, plans still rely on provider communication to stay informed about a member's progress. Maintaining regular updates with the plan strengthens the partnership and helps prevent delays or misunderstandings later in treatment.
Right. So while prior authorization isn't allowed, plan notification is still required. So keeping that dialogue going with the plan helps ensure smoother coordination and fewer disruptions in care. And this distinction really matters. Let's talk a bit about timing. There are state-mandated timelines that allow providers to focus on care before plans begin a deeper review. But those timelines depend on the provider taking specific actions upfront.
Yes, if a provider notifies the plan within 2 business days and submits an initial treatment plan, then for inpatient or residential, the plan can't conduct a concurrent review for the first 28 days. For outpatient, it's the first 4 weeks or up to 28 visits. During this period, providers can focus on delivering care without having to justify it through concurrent review. But if that notification doesn't happen, the plan may begin concurrent review right away.
And to add an important clarification, after that initial 4-week or 28 visit period, concurrent review is only permitted for outlier programs. These are programs whose service utilization patterns fall outside the expected clinical practice. They're listed in joint guidance from OMH and OASAS, which is linked on your screen. OASAS encourages plans to focus on unusual or outlier cases and does not permit routine requests for treatment plan updates in otherwise typical outpatient or opiate treatment utilization. For reference, expected average frequencies are approximately 30 to 50 visits per year for OASAS outpatient clinic services and 150 to 200 visits per year for opioid treatment program services and programs that dispense medication for opioid use disorder. So for most providers, concurrent review beyond that initial 4-week window should not be routine. It's limited to those rare situations where service use is significantly outside the expected pattern. This distinction is important because it reinforces that plans cannot simply apply ongoing concurrent review across the board, only when data shows true outlier trend. So we also mentioned retrospective review. Now this happens after the provider has already delivered services, but the plan can still review those services delivered for medical necessity even after the services have been delivered.
Yes, that's right. Retrospective review is used when a plan evaluates services after they've been provided, especially during the early part of a treatment episode when prior authorization and concurrent review are not allowed. For example, the first 28 days of inpatient or residential treatment, or the first 4 weeks or 28 visits in outpatient.
So while the plans can't stop in during that initial phase, they can and may often do look back to determine whether the services were medically necessary.
Yes, exactly. They'll use tools like Locator and other OASIS designated clinical guidelines to determine whether the level of care was appropriate. And if the documentation doesn't support the medical necessity, they can deny payment for some or all of those services.
So then that brings us back to the importance of documentation that we talked about earlier. But there's also another piece of guidance here, provider engagement with the plan. So even though there's no formal concurrent review during these early days, OSS guidance encourages providers to initiate consultation with the plan around or before day 14 of treatment.
Yes, and that's a key point, Shazia. OASIS requires that providers and plans engage in periodic consultation starting at or before the 14th day of treatment to discuss the clinical course, progress, and any anticipated needs for extended care. This communication doesn't trigger utilization review, but it helps keep the plan informed and can smooth out the process when review does eventually happen.
And the state requires notification of admission, right?
They do. Even though prior authorization isn't allowed during the early phase, the state requires providers to notify the plan of the admission within 2 business days of the person's admission. That's different from utilization review, but it's still an administrative requirement that providers need to follow.
So when you put it all together, even though prior approval and concurrent review aren't allowed in those first few weeks, there's still a requirement of early communication, where the addiction provider must conduct at least one clinical consultation with the insurer at or before the 14th day of treatment. And this applies to both services delivered in either an inpatient, residential, or outpatient setting. And then, after services are provided, plans may conduct retrospective review to determine whether care met medical necessity criteria.
Exactly, Shazia. That's why clear documentation, timely communication, and use of OASIS approved tools are all essential. If there is a denial, providers still have the right to appeal, and they should be prepared to support their clinical decision making with objective criteria.
So early engagement with the plan, even outside of formal review, can really help set the stage for a smoother retrospective review later on. So let's talk about communication with plans and what that communication looks like over time, from the start of treatment through to discharge.
It starts with initial notification, informing the plan of the admission and submitting the initial treatment plan within 2 business days. That's initial notification. Then there's periodic consultation, usually around the 14-day mark that we mentioned earlier. It's an opportunity to update the plan on treatment progress and flag any upcoming changes, like a step down in care. After that, if the early phase is ended, concurrent review may begin. This is where the plan can start asking for updates and justification for continued care using the locator's concurrent module. And finally, at discharge, providers need to give the plan a written discharge plan, a medication plan, and notify them if the person left against medical advice, AMA, or went missing. For some patients, this discharge communication is as important as the admission step. It can affect aftercare, coordination, and reimbursement.
So periodic communication isn't just a checkbox. It helps plans assess progress, anticipate needs, and better coordinate care. And providers can benefit as well by staying ahead of issues, avoiding disruptions in treatment, and reinforcing medical necessity. It's really about working together in a way that actually supports the client. So there's a real world example, Jean, here that would be great to share, where we at OASAS have seen during our plan reviews. So there was a provider who had a patient with multiple inpatient stays, some which resulted with the patient leaving against medical advice and was admitted again. The plan had reached out to the provider a week after the patient's admission for an update, and the provider shared that the patient was homeless and food insecure. So with that information, the plan was able to step in, offering housing, meals, reconnecting the patient to outpatient supports, and scheduling primary care. So that one update changed the course of care where the patient might have slipped through the cracks otherwise. So from an operational perspective, programs also need internal systems to make all this work smoothly. So Jean, what can providers do to manage this communication more efficiently?
First, know your plan contacts. If you don't have a point person, the MCTAC plan matrix is a great starting place. The MCTAC plan matrix includes contacts for each plan, claim submission methods, fax, portal, email, and any forms, claims, or documentation templates required. It's kept up to date and can save time tracking down information. Next, understand how each plan accepts documentation. Some use portals, some want secure email, others still use fax. Make sure your staff is clear on those workflows. Internally, have a standard process for collecting and submitting this information, ideally one that gets reviewed at least once per year. Build in periodic consultations, even when not explicitly required. They help reinforce clinical necessity and build good relationships with plan staff. Finally, always align your documentation with the locator. When plans and providers are using the same framework, it minimizes misunderstandings and supports timely authorization.
And the effort on the front end can really pay off, not just for compliance, but for smoother communication, fewer billing issues, and stronger continuity of care. Let's bring everything we've discussed into one place. On your screen, you'll see a summary table that outlines the key utilization review requirements by payer type, commercial and Medicaid. Within each payer, the table further breaks down requirements by coverage type, commercial in-network, out-of-network, or non-New York State, and Medicaid fee-for-service, as well as managed care, both in-network and out-of-network. The table shows when locator is required, whether prior authorization is permitted, when plan concurrent review can occur, and what the plan notification requirements are after a patient is admitted, whether that's for inpatient, residential, or outpatient treatment. And one thing to highlight for Medicaid managed care, after that initial 4-week or 28-visit period for outpatient treatment, concurrent review is allowed only for those outlier programs. For all others, plans are not permitted to routinely request treatment plan updates or impose additional review requirements. Expected utilization averages are 30 to 50 visits annually for outpatient clinic services and 150 to 200 for opioid treatment programs and programs that dispense medications for opioid use disorder. Jean, with all that in mind, what are the main takeaways that providers should know when navigating these different requirements?
Shazia, I'd say focus on 3 areas. 1, prior authorization is mostly prohibited, but only if you're in compliance with notification timelines. 2, for concurrent review, understand when it can start and what triggers that. And 3, keep track of the differences between commercial versus Medicaid, in-network versus out-of-network. That's often where errors or delays occur.
So even though the protections are strong, whether they work in practice really depends on providers following through with timely documentation and ongoing communication with the plans. So for anyone looking to dive deeper, there are a few key documents worth bookmarking. Jean, anything you'd like to highlight here?
Yes, the OASAS guidance document provides practical steps for implementing utilization review processes within your program. Another valuable resource is the MCTAC MCO Plan Matrix, which we mentioned earlier. This is an online interactive tool designed to help behavioral health providers navigate the varying requirements of New York's Medicaid managed care organizations. This tool consolidates plan-specific information in one convenient place, allowing you to easily compare how different MCOs handle key areas like billing, utilization management, and provider relations. After registering for free, you can search for plans by county, region, or use the drop-down menus to filter by mainstream or MAP plans. Each search result is organized by tabs, with each tab focusing on a specific operational area. Hosted on the MCTAP website, the MCO Plan Matrix is updated regularly. It serves as an excellent reference for frontline staff, billing teams, and program managers. It helps ensure you're following each plan's requirements while streamlining communication and compliance. Two other important resources include DFAS Circular Letter number 13, clarifies the insurance law and can be helpful if you're ever facing pushback from a plan. And for Medicaid providers, the Managed Care Model Contract is where you'll find the actual plan obligations. It's the fine print behind the policies.
And these resources can also support staff during training and internal policy development, especially for program directors or compliance teams. And so this brings us to the end of our presentation. For any questions after viewing this presentation or any presentation in this series, I encourage you to reach out to the Pick'em team at pick'em@oasas.ny.gov. So before we close, Jean, any final thoughts?
Just that understanding utilization review isn't just about compliance. It's about ensuring that our documentation reflects the care we're providing, supports continued treatment, and reduces disruptions for the people we serve.
Well said. And thank you, Jean, for sharing your expertise. And thank you, everybody, for tuning in.